Hello and welcome to Indigenous Allyship and Culturally Safe Care. My name is Shika McGowan. I work in the engagement team here at the Canadian Medical Association, and I will be your facilitator for this session. Before we get started, just a couple of housekeeping type things. As you come into this room, can you make sure that your microphones are on mute? And if possible, if you could turn on your camera so we can see your faces, it'd be great. It just sort of helps our speakers and to see people's faces as they do their talks. As well, we're asking if each of you can please add your first and last names to your profile, and you do this by clicking on your own tile and clicking rename. This just makes sure when we get to the breakout part of our session, we can actually call you by your correct name. Thanks, everyone. Finally, our last housekeeping thing is that we are recording today's session, and it's only the plenary part of today for the purposes of note-taking. We also will be sharing a video excerpt of the panel session following today. To start us off, I'd like to invite my colleague from our Indigenous Health team, Dr. Sarah Williams, to share a blessing so that we might approach today's session with good intentions. Over to you, Dr. Williams.
Hi, Shika. Thank you so much. Hi, everybody. I'm Dr. Sarah Williams. I am Anishinaabe from Curve Lake First Nations, and I currently live in Victoria, BC, where I'm calling in today from the land of the Algonquin-speaking people who are Coast Salish and belong to the Esquimalt and Songhees First Nations. It's a privilege to speak with you today, and we wanted to start the session by acknowledging the late Murray Sinclair, who passed away earlier this month. As the chair of the Truth and Reconciliation Commission of Canada, Murray Sinclair helped expose the deep injustices experienced by Indigenous people in Canada's Indian residential schools. His work was a call to action, urging all Canadians to educate themselves and take responsibility for Canada's true history and legacy of colonialism. Murray Sinclair had a vision of reconciliation, which emphasized that healing is not simply acknowledging the past, but involves taking action to address its ongoing impacts and harms. In healthcare, this means confronting the systemic barriers that exclude Indigenous people and working to build a system that is human-centered, free of racism, and culturally safe. One of Murray Sinclair's greatest teachings was on the importance of listening. He said healing begins when we truly listen to the stories and experiences of those who have been harmed. In healthcare, this means engaging with Indigenous communities, understanding the impacts of lived experiences, and integrating cultural perspectives into healing and healthcare practices. As we honor Murray Sinclair's legacy, let us renew our commitment to the principles of justice, equity, and cultural safety. Let us work together to build a healthcare system that respects the rights of Indigenous people and provides care that is compassionate and culturally safe. Thank you.
Thank you, Dr. Williams, for reminding us of the beautiful words and vision of reconciliation of Senator Murray Sinclair. I'd now like to invite CMA President, Dr. Joss Reimer, to share a land acknowledgement and some opening remarks.
Thank you, Dr. Williams, and thank you, Shika, and hello to everyone, and thank you for joining us today. Before I begin, I want to acknowledge that I live in Winnipeg, which is Treaty 1 territory. It is the traditional territory of the Anishinaabe, the Cree, Ojibwe, Dakota, Dene people, and also the homeland of the Red River Métis. However, today I'm joining you from Ottawa, which is the traditional territory and unceded land of the Algonquin Anishinaabe people who have cared for this land for time immemorial. And I want specifically to make the acknowledgement to reflect on the medical community's commitment to listening and learning and walking the path towards reconciliation. As I'm sure you all know, we issued an apology on behalf of all physicians for the current and ongoing harms that Inuit, Métis, and First Nations people have experienced in Canada and continue to experience. And so as we start to have this conversation today, I think it's really critical to frame the discussion around the lands that we're in and the people who have been in these lands before us and continue to live here and continue to experience harms in the healthcare system. So wherever you are, I encourage you to take a moment to think about the lands that you live in, the people who live in that land and have cared for it, and either in the chat or quietly to yourself to share a bit of that reflection about where you are and how the people who have cared for that land impact your work and how your work impacts them. So please do share in the chat if you feel comfortable, and if not, just to yourself is great as well. As physicians, we see the many ways that the Canadian health system has in the past and how today it continues to harm Indigenous peoples. In fact, I work in the hospital where Brian Sinclair died after being neglected in the emergency room for waiting for 30 hours without receiving care. And so every day that I go to work is a chance to reflect on his experience, but his experience not just for him, but how it also reflects on the experience that so many other people have in that hospital, in other hospitals, and the other stories that we hear from people who are trying to use the Canadian healthcare system. In my work, I work largely with pregnant patients. And so I've heard from many Indigenous mothers who don't come to their prenatal appointments because they're terrified of their children being taken away from them. I've served obstetrical patients who come from small communities in Nunavut who are flown down for care to Winnipeg a month before their due date. And so they're facing a monumental life event in a city that they've never known, where the culture is different, the food is different, the language is different, where they're living out of a suitcase in temporary housing, all while dealing with the symptoms of pregnancy and often having to leave their other children and certainly other family members at home. And I've also heard from Indigenous colleagues about their experiences in medicine and how they're constantly battling assumptions from non-Indigenous patients and peers while also facing their own systemic barriers. So whether that be in relation to equitable access for Indigenous populations, the right to determine the treatment they receive, or through the lack of representation of Indigenous knowledge systems, such as Indigenous medicines and healing practices in the health system. And I am sure that many of you have similar experiences to my own, where you have bared witness to the injustices in our health system. And I know that you're here today because you believe in making a better health system for all of our patients and for our colleagues. And so while we have taken some steps to improve our system, there's no question that positive change has occurred. There is much work that remains to be done. And as we continue to see these harms occurring, that's something that we need to take seriously in our discussion today, but also what we take away from today to bring back to the communities that we work in. So at the CMA, as we deepen our understanding of reconciliation, we've made it a priority to help ensure equitable healthcare for Indigenous communities and safer working and learning environments for Indigenous physicians and Indigenous medical learners. And a meaningful step in that work is acknowledging and taking responsibility for the harms experienced by Indigenous peoples in their interactions with physicians within the health system. And so, as I mentioned right at the beginning, as many, if not all of you are aware, on September 18th, the CMA apologized for its role and the role of the medical profession in these harms. So as the national voice of physicians, this public apology was critical in advancing meaningful change in the healthcare system and also critical to improve relationships between physicians, medical institutions, and Indigenous peoples. The apology was also part of our response to the Truth and Reconciliation Commission of Canada's call to action and a specific recommendation made by the CMA's Indigenous Guiding Circle, which is 16 First Nations, Inuit, and Métis elders, leaders, and knowledge keepers who have been fundamental in the work that the CMA is taking on to improve the way we interact with Indigenous communities and the work that we're doing to contribute to reconciliation in Canada. So I have to really humbly thank everyone who has put in so much effort to guiding the CMA and guiding me personally in that apology, in that moment, and in the work that we take forward. So that includes the Indigenous Guiding Circle, includes community members, physicians. I thank you for advising us on how we can move forward in a good way. But an apology in and of itself is just words. So it is a very important first step, but it is only a first step. And if it doesn't come with action, it can cause more harm than good. And so the CMA is now moving forward with a reconciliation plan that outlines how we will advance health and well-being for Indigenous peoples, how we will support the medical profession's journey towards truth and reconciliation, and promote internal reconciliation as an organization. We are already taking some action towards this plan. For example, we are amplifying Indigenous voices to government. So we have taken part in testifying to committee to help shape the First Nations Clean Water Act, supporting the legislation that would criminalize forced and coerced sterilization. We've also called on government to fund Indigenous-led land-based approaches to addressing climate change. Another commitment that we are starting to work on is that we will be reviewing the CMA Code of Ethics and Professionalism with the goal of strengthening provisions related to anti-Indigenous racism and discrimination specifically, as well as discrimination in all other forms. We are providing funding to partners who are actively working to improve Indigenous health and well-being by dismantling racism and discrimination. Most recently, we supported the Winds of Change project, which was an expansion of an Indigenous-led national standard for cultural safety and humility. We have developed a new guide for Indigenous physicians and learners with the Indigenous Physicians Association of Canada to share resources on wellness and healing. And of course, we're coming together today for a discussion around allyship and cultural safety to support all physicians in their path of reconciliation. So to realize meaningful change, the CMA cannot and should not act alone. We are committed to taking this next part of our journey in partnership and reciprocity with First Nations, Inuit, and Métis peoples, and alongside members of the medical profession and other medical organizations. Today's session is an opportunity to discuss and share as colleagues how Indigenous rights should be enshrined in healthcare systems and how we should change the care that we provide to our patients. We have had a few physicians on hand to share their valuable experiences with you, and I am excited to listen and learn from them. And so today I ask that you as well listen and reflect on what you can be doing to influence change. As individuals, we may or may not be responsible for what happened in the past, but we are certainly responsible for what happens in the future. So no matter what career stage you are at, no matter what career you are in, we can all keep learning, we can all help right the wrongs that have happened, and we can all stop ongoing harms in their tracks. And so to that end, I very much look forward to our session today. I look forward to hearing from the folks that have joined us to share their expertise and their experiences. And I look forward to hearing from all of you who have joined and will be sharing your experience with us as well. And I will pass it back to Shika to get us going to the next step.
Thanks, Dr. Reimer. All right, so we're going to talk a little bit about our goals for today, which will show up on your screen. Dr. Reimer spoke about CMA's journey to reconciliation and our commitment to prioritize equitable healthcare for Indigenous communities and safer working and learning environments for Indigenous physicians and medical learners. As Dr. Reimer mentioned, this means working alongside Indigenous people. It also means listening. It also means learning and really taking the time to understand the issues that are contributing to the harms that we're seeing in Indigenous communities. Many of you in the registration process for this session told us that you're looking for support, you're looking for direction, and you're looking for ways that you can foster allyship, both from an individual perspective, but also from an organization perspective. So today what we're going to do is we're going to hear more about Indigenous rights to self-determination. We're going to talk about practical examples of allyship. We're going to spend some time also reflecting on what you heard. What does it mean for you? And where are there opportunities for each one of us to strengthen relationships with Indigenous communities and affect change in our spheres of influence? In terms of our agenda today, in a moment, we're going to hear from our panelists. We're then going to have some Q&A period. In the latter half of the session, we're going to turn it back to you. We're going to break out into smaller groups and we're going to reflect on what we heard. And we're going to talk about some of the actions you could be taking and the actions we could be taking collectively to advance reconciliation. We're then going to share some next steps before we close. It's a lot to get through in 2 hours, as you can see. I'm going to commit to keeping us to time so we can get through all the items on this agenda and make sure that you have the time to adequately hear from the panelists, but also time to hear from one another. Right? At any time today, please use the chat if you have a comment to make or if you have a question. We'll try our best to get us to as many questions as we can, but please use that just so that you are heard, and we make sure we read each and every comment. All right. Now, before we get to our panelists, we thought we'd do a little bit of a warm-up just to get us into the frame of mind of allyship and reconciliation. So in a moment, you're going to see a poll show up on your screen. So I want you to tell us a little bit about where you are, either from an individual level or organizational level. Where are you in your reconciliation journey? Take a moment to do that. Okay, everything's come back fast and furious so far. Let me give it another few seconds. All right. I'm going to share the results. Very interesting. So we have a mix of folks. About half of us have taken a few steps. Others are still sort of trying to figure out where to make those first few steps. But most of us are have taken some steps towards that journey, which is fantastic. So when we get to the breakout groups, please make sure you share this because everyone's starting from a different point, and that's okay. All right, so let's go on to the next question that we have for you. The next question is not a poll, it's in the chat, but what we want you to do is answer this question. When you think of reconciliation in healthcare, what comes to mind for you? Just don't overthink it, put the first few words that come to mind for you into the chat. I'm going to look over here because I'm looking on my other screen, but I am paying attention. All right, so I'm seeing equitable care, relationships, better relationships, addressing health disparities, inclusion, not being afraid. And that's a tough one because this can feel scary to folks, right? This is a tough journey. Visibility, creating safety, some kind of governance, action. Action's a big word, especially when it comes to this work. We've got to move towards change. Oh, I love it. Community-centered, trauma-informed, relationship-based, best care, opportunities for all, exceptional health, looking at marginalized groups and making sure everyone feels as part of that. Thank you for sharing that. All great words and great visions for what this could be and what reconciliation could be. As you keep on coming, I will keep us going to the next question though. Oh, just before we go, measurements is something I didn't see before either. And justice. Indigenous people providing healthcare. What a beautiful vision, right? Taking care of their people in ways that make sense for ensure cultural safety. Love it. Okay, our next question for you, our third question, this is the final question that we're going to have for you, is when it comes to reconciliation, what role do you see for physicians and medical learners in that journey? Take a moment and put that in the chat, please. Sharing the experience of being human, what unites us, which is more than what divides us, 100%, right? We have a more that's similar. And can we use that as a starting point? Listening and supporting, partnerships, providing the best care in your capacity, ensuring patients should come and not be scared of you, right? Creating that safety. Partnership, not paternalism. Love it. Co-creation in an intervention. Being leaders, being an example of action, supporting modeling care. These are all fantastic. And what I'm hearing is this desire to partner, desire to work together, right? To walking alongside Indigenous people. And that's part of the role. I love it. Knowing the whole person, being an ally, being the best care without judging. All fantastic. And what I love is, what I'm hearing is this real desire to do something different from where we are. And I think that's the basis for where we want to continue this journey. We're gonna ask our panelists to sort of take that as we start to go into our panel session, take the words that we're hearing today and build on that with their example. So thank you everyone for taking a few moments and just answering those questions. Now we'll get to our panel session because I know everyone's really excited to hear from all three of them. I'd like to introduce each one of them. Our first panelist is Dr. Ojista Horn. Dr. Horn is from the Ganyan Gayhawk or Mohawk communities of the Kanawake and Akwesasne. For 16 years, she has worked as a family physician. She supervises medical students and family medicine residents during the rural rotations in Akwesasne and is currently in her new role as Medical Director of Clinical Care in the Department of Health at Akwesasne. She teaches the complexities of providing care to Indigenous people and their communities, and she draws on both Western and traditional paradigms and focuses on the effects of the environment and pollution on health. Our next panelist is Dr. Melissa Lamb. Dr. Lamb is a Vancouver family physician who works in rural and northern communities within Canada. She is president of the Canadian Association of Physicians for the Environment, or what we know as CAPE, and she's also director of PARC, Canada's National Nature Prescription Program powered by BC Parks Foundation. She's an internationally recognized leader in the field of nature, biodiversity, and health, and is also engaged in advocacy and policy work on a broad range of issues, including sustainable healthcare. Our third panelist is Dr. Sarah L'Esperance. Dr. L'Esperance is a rural generalist physician who's currently dividing her time in clinical practice between Nunavut and the region of the Mi'kmaqi, that is Nova Scotia. She is immediate past president of the Society of Rural Physicians of Canada and director at large on the board of the College of Family Physicians. She works extensively in Northern Canada and has held a variety of leadership and teaching roles in medical education and published in a number of areas, including latent tuberculosis treatment in Nunavut. Our moderator today is Dr. Reimer. And so I will direct it over to you, Dr. Reimer, to get us started.
Thank you, Shika, and thank you so much to all of our panelists for joining us today. I thought we would start today's session with Dr. Gisto Horn. Dr. Horn, I was hoping we could start by discussing the right to self-determination for Indigenous peoples and the relationship to their health and wellness. I know that you have shared many times that medical learners and physicians don't have a solid understanding of the structural inequities that perpetuate harms to Indigenous peoples, especially when it comes to self-determination. So what are the underlying causes of these inequities, and how does it relate to health outcomes?
Okay, thank you. Thank you. So I am happy to be here today. I'm talking to you from Akwesasne, and I'm Ganyakahaga or Mohawk, and a family doctor. And so when we're talking about the underlying causes of persistent inequities, we have to really talk about the social determinants of health. As were outlined in the 1970s by the Lalonde Report, we were really ahead of our time in Canada talking about health being not just something that we get in a clinic or in a hospital, but also all these other determinants, which actually make up about 80% of our health. Now, what's very important to recognize is that there is an inequitable distribution of the social determinants of health because of three main, and many others, but three main laws. The first one is the British North American Act, which is what made the Dominion of Canada in 1867. And that's what outlined the federal, the provincial, and the municipal mandates to provide services. And we are separate from Canadians in that. The second one is the Indian Act itself in 1876, which basically regulates all of our lives, and including the provision of health services. And then the third one is the Indian Lands Act, which removed us from our lands and gave all of the stewardship of the lands to the provinces. So we were cut off from any economic ventures outside of our small communities, as well as being able to preserve the biodiversity and have really healthy relationships with the land. So we have this inequitable health because of a very long history of being systematically separated from the things that made us healthy. So I don't know if you want me to continue to talk about how that relates to health outcomes, or you wanted to
Please
just...
do.
Okay, so
No, I would love to hear about how it relates to health outcomes.
Okay, so for instance, when I talk about the way that we once were very, very healthy. We were self-sufficient, self-reliant. We had really incredible relationships with other Indigenous peoples in our areas. We were put in our specific places to steward the land and take care of the land and make sure there was a balance between all parts of creation so that we could continue to live in a good way. And where I come from, we have a number of really important ways of participating and entering into relationships, which I will talk about later. But they were enshrined in our wampum belts, and so these wampum belts are super, super important. The one that I'll tell you right now is this one. This is the dish with one spoon. And this is the one that came from out of the area that's around in the Ontario, north of Lake Ontario and St. Lawrence. And in that, we all live in this area. We share the area. We have a right to forage and hunt and fish and to pass through unmolested through this area of land. We all need to eat. We all need to breathe. We all need to have a life. And so there's one area we can share it. This is a common land, and I think that this is really important to reflect, because right now we have decreasing resources. We have a finite earth, and right now we are having problems matching our needs because we're not realizing that the earth is finite, and so we all are in this together in terms of having a human experience. And so the whole climate movement and other things are related to that. So the dish with one spoon is a really important reminder. And we have so many wampum belts that are pre-contact, which really describe the way that we think relationships should be between ourselves, our family members, community members, the environment, the past, the future, and the spiritual world and the other beings. And so because of the past being, we were systematically removed from all those relationships with all the acts that were put in place. We are now so unhealthy. And so we're talking about access to general things like transportation, communications, sustainable, healthy food, healthy, clean water, access to healthcare services, education. Most communities do not even have a high school in their communities. So all of and waste management and things like economic development, all the things that Canadians do not actually pay attention to as to how those services are provided to them. It's actually different for Indigenous people. So if we do understand how Canada is set up, then we can start understanding the inequitable distribution of these services and why we have the persistent problems we have today.
Thank you so much, Dr. Horn. And I really appreciate the way you explained the legal background, the historical background, and then also how the links between the land and health really matter to Indigenous peoples and to the communities. That was really helpful. And I'm sure many of us don't fully know or understand the legal frameworks that have taken us to where we are today. So thank you. I'm going to bring in Dr. Lem into the conversation to try to dive a bit deeper into health and the environment. So welcome. We've been discussing environmental harms that disproportionately affect Indigenous peoples, and we know that health outcomes are related to harms outside of the health system. In fact, we know what the determinants of health. The health system is a smaller proportion of health outcomes than many of the other health determinants. What have you seen as a physician through your work with CAPE or your work on the ground with how environmental racism contributes to worse health outcomes in Indigenous communities, and what is important for physicians to be aware of when caring for Indigenous peoples on this topic?
Well, I think, Joss, you've mentioned this, and Ojisto, you've also mentioned this. I think the first thing we need to be aware of is how important those ecological determinants of health, which include clean air, clean water, unpolluted food, and a stable climate, are for all of our health. And so if the lands and waters that your family has been connected to since time immemorial are polluted, or if a wildfire evacuates your reserve, like what happened with 5 First Nations near Lytton when it burned to the ground during the 2021 heat dome here in BC, these social determinants of health, like education, income, housing, and your ability to access healthcare are severely harmed. And this is why the World Health Organization calls climate change the greatest threat to health of the 21st century, and why Indigenous peoples and communities are disproportionately harmed, not only because they're starting out with lower health status due to multiple systemic factors, but also because of this closer connection to the land that Ogisto mentioned. And I also want to mention in my own context that I live and practice in Vancouver on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, where close to 60% of our city's greenhouse gas emissions come from the natural gas that we use to heat our buildings. But this gas, unfortunately, is far from natural because the vast majority is extracted using a highly polluting process called hydraulic fracturing or fracking on lands largely stewarded by Indigenous peoples in Northeast BC. And we know that fracking pollutes the land, water, and air with chemicals that are harmful for human health. So it's not surprising that doctors in Northeast BC are sounding alarm bells about adverse pregnancy outcomes, about higher rates of cancer and lung disease in the local population. Research Scientific research also shows 3.5 times higher levels of toxic benzene metabolites in the urine of Indigenous women compared to non-Indigenous women, which we know benzene is a chemical used in fracking that the WHO says there's no safe exposure limit to. So the fossil fuel industry, which is driving climate change, is also directly harming the health of people who live near these extraction sites. So something I think we all need to be aware of as clinicians, particularly if we work with Indigenous peoples who live in or come from these industrialized areas, is that they're at higher risk for all kinds of different disease outcomes. So when an Indigenous patient comes in with a non-specific symptom like fatigue or shortness of breath or brain fog, we should have a higher index of suspicion for cancer or interstitial pulmonary fibrosis, for example, and ask questions about their potential environmental exposures because environmental racism means that many Indigenous nations live in a toxic soup that's not regulated or monitored to the same degree as in non-Indigenous communities.
So those are some sobering facts. Maybe we can shift to talk about what needs to change. When we talk about ways to change the system, we often talk about the importance of allyship, the need for cultural safety in healthcare. And we heard from attendees that it's not always clear what allyship looks like or what it means to demonstrate allyship versus being a bystander or supporter. Dr. Horn, I want to come back to you for a second. What would you say allyship looks like on an organizational level? And then also, what can it look like more on the micro level in, for example, the physician-patient relationship?
Okay, thank you for that question. So it's a big one, and I know it's a pervasive one here in Canada. The first thing, when we talk about allyship, that is actually a relationship, and the question is, how do you make a relationship that you've never had before? And so we have to look at keys from our past, and the most important thing about a relationship is you have to have accept the truth. What are the truths that you are both agreeing to? We have certain truths, and the society, Canadian society, has their truths, and they're not always the same truths. So we need to embark on a way of finding those truths, and that's what CMA did when they did their apology. They went back into their records to find, where places and situations where they substantively were part of some of the inequities that we're seeing today. And so you have to accept the truth. Now, how do you go about finding that truth? So we have many ways, and in our ways to find the truth. And I really wanted to bring your attention to another one of really important. This is another wampum belt, and it is. Sorry, I guess you can't see it, but anyway. It is the Hiawatha Belt, or the Five Nations flag. You would see it when you would, we've turned it into the Haudenosaunee flag, which is the Iroquois flag. And basically, the main story of the creation of our confederacy, there are many, many stories that you can draw from this, but one very important one was there was a woman who was living on her own in the woods at a crossroads, and she was kind of unhappy because she was ostracized. And people who were traveling on those crossroads, as they were going for diplomatic or hunting or for wars or whatever, they would stop at her place and they would get food and have some shelter, and she would speak with them. And she became the person who knew what was going on, the information. So her name was Jagusaze, and she's actually kind of hidden in the story, but I like to bring her out because of her role. She would take this information and use it for a not a good means, or sometimes good. But the important thing is when she decided that she was going to accept the Great Law of Peace, when she agreed to be peaceful, she agreed to not change or manipulate the truth. So this has to do with today, misinformation and disinformation. It's very important that if we need the truth, we have to have the right information. And that means we have to listen to all parts of what the issue is. And some of that requires that you have to be very humble, and you have to go about it in a way that doesn't make you feel emotional. You have to go about it in a good way. And so there's something called the condolence ceremonies, and in the condolence ceremonies, we this is a ceremony where you enter into a discussion in a good way, and you have to and very quickly there are three wampum strings, and these strings each are a different part of the deliberation. One is you take a hide and you clean your eyes so that you can see clearly. One is you take a feather and you clean your ears so everything is heard as it was said, and so it doesn't change. And then you have some clear water and you drink it, and your throat is clear, and you're able to speak in a good way, and you're able to get those words out. And so you have to participate in a good way, in a way that is towards good. So when you have a relationship, you have to not manipulate the truth. You have to participate without bringing your previous emotions in. We have this other one. This is it represents the mat that our chiefs would have sat on. And this mat, every time a chief either dies or is not able to be a chief anymore, all of the things that while he sat on that mat would have been on that mat. So if he was got sick or had been in war or had been had bad relationships with other people, that mat would have gotten dirty. And so when you bring in the new chief and you have him sit on that mat, you're not going to have him sit on a mat that's dirty. You're going to clean the reeds of that mat to make it all clean again so that he can sit on. Meaning you don't take into your mandate the things from the past into without like you don't just bring old grievances and keep pushing them forward through your mandates. So we have to remember that we can start over again, and it's important to start over again. We have to, and so that's the importance of this mat. Now, each of these wampums from these are old ideas that are still relevant today, and that's why I bring them up. We have these teachings in our places, in our cultures, and we need to start teaching them so that we can have a different approach to how we can become allies. Allyship is about a relationship. The last one I wanted to mention, in the interests of time, is this one, and this is the two-row wampum. The two-row wampum is a well-known wampum belt, and it was originally made in the 1613 between the Haudenosaunee and the Dutch. And what it was that we would each go down the river of life side by side. We would be in our canoe, and they would be in their ship, and we would go and we would keep our governance structures, our laws, our rights, our customs, our language, and we would go in our boat and you would go in your boat. We have lots and lots of room here. This is a pretty big land. Remember, dish with one spoon, we're sharing it, but you're going to go in your vessel, we'll be in our vessel, and we're going to go straight down that river together, and we're not going to interfere with each other. And so that's when allyship, it means that you have to recognize that you are down the river of life together, but one doesn't go on top of the other. This one here is the coming of the people with the white faces, which is basically two thick lines that are in parallel, and the skinny little skinny little line in the middle. And these are all in parallel. The two thicker ones represent the indigenous people, and the thinner one represents the early people who came to this land. And we supported them and through this idea of the two-row wampum to teach them how to live here, because it was a very, very difficult place to live. And so we supported them, and we even help protect them. And so but the idea of non-interference and just supporting was a very, very tantamount in the way that we conducted ourselves in relation to other people. And so when we're talking about allyship, recognize what boat you're in and stay in that boat, and don't try and put yourself over the other people. Allyship is about going side by side down the river of life. We, after all, want to talk with people. We can't talk to a corporation or an organization. We talk to people, and people are very reasonable when you think about doing all of this in a good way. Thank you. I'll stop there.
Well, thank you so much. Maybe I'll turn back to Dr. Lem then to share some examples based on your experience working with Indigenous communities on what allyship can look like.
Sure, thanks, Joss. Well, I mentioned earlier that I have a family practice in Vancouver, but a major part of my practice since the beginning of my career has also been rural medicine. So my first job, where I worked for the first 1 to 2 years of my career, was as a full-service rural family doc in Northwest BC on Gitxsan and Wet'suwet'en territory in a town called Hazelton, or the Three Hazeltons. And I would say a positive example of allyship would be my experiences in that hospital and with those staff. We had a local population that was 80% Indigenous, and I remember there being this culture of mutual respect and cooperation at the time between settlers and the Gitxsan and Wet'suwet'en. And I remember this one example. We would have educational rounds for staff every week that were typically built around some kind of dry journal article. But one week I helped organize staff rounds and invited Roy Henry Vickers, who lives on those lands, who's a famous Indigenous artist, if you didn't know, of mixed Tsimshian, Haida, Heiltsuk, and English heritage. And I also invited his sister, Patricia Vickers, who's an academic, to teach our staff about Indigenous ways of healing. And I remember the room was absolutely packed with current and retired doctors and staff, so way more than the 5 who would usually show up on for morning rounds. And at the time, so I'm dating myself, this was almost 20 years ago when I was a new doc. Indigenous knowledge keepers, they had never been invited to participate in doctors' academic rounds at the hospital before. And even then, 20 years ago, it showed there was a huge appetite for it. So I think we need to take those opportunities that we can to change the way that we learn on a broader scale so that we can provide care in a way that honors our whole patient, which is something that one of the participants put in the chat. And, I hesitate to mention this next example because it's not an example of allyship, but it illustrates the opposite which can happen if we're not all allies within the healthcare system. And so this is a really painful experience that I actually had providing care in another majority Indigenous community in Sioux Lookout. So after my time in Hazelton, which was kind of like this glowing time, even though it was, very stressful objectively stressful from a new physician perspective, I really loved it. But then I moved back to Toronto, where I was born, for several years, and started doing locums in Northern Ontario as well. And one of my first locums was in Sioux Lookout. And on my very first ER shift there as staff, which was actually where I did my first clinical rotation as a third-year med student, a major contributor to basically the first patient I saw that day. So their death was racism by staff. So essentially she'd been turned away by nurses the night before who had assumed her confusion and ataxia were because she was drunk, but she actually had a subdural hemorrhage. And so by the time she came to me in the morning, her GCS was 7, she had a blown pupil, and she ended up dying after we got her intubated and transferred her to Thunder Bay. And as a new doctor, it was absolutely devastating. And I still get emotional, as you can tell, today when I think about it. But it underlined for me how important it is for team members at every level to be allies, because it can literally mean life or death for Indigenous patients. And it's something I think about all the time when I continue to practice in rural communities in the North and within BC, and in the work that I do with CAPE, is thinking about how we can be good allies to make sure that lives are saved and not harmed. Thanks.
Well, thank you for sharing both the good and the bad examples, because I think there's a lot to learn from both. And Dr. Horn, thank you for sharing such powerful examples of Indigenous knowledge that goes back generations that can still inform the work that we're doing now. So those are really helpful. But we have not yet heard from Dr. L'Esperance, so I'd like to bring you into the discussion as well. Thank you for being here as well. And we would really love to hear about your journey of allyship and experiences working in the remote region that you do, which in Nunavut or other remote regions as well. But there may be other physicians here who work in similar settings, similar remote communities or remote regions. What have you learned in your practice, and also as past president of the Society of Rural Physicians, on this topic, and what can we learn from your experiences?
Thanks so much, Joss. And, I think to me, one of the first things I think I've learned is I still have so much to learn. I think there's so much truth still to learn, and even, hearing Dr. Horn today speaking about some of the teachings, I think as I've gone along in my career, I see so many more opportunities to expand my knowledge and understanding. And then, I think really, and this was touched on as well, if we come from a place of really having good intentions, I've found that people are really generous in terms of sharing their knowledge and helping us along the way. As a settler, I don't feel that this is, my role to kind of take on this, but it's my role to understand and really, do my work to change the system we're working in, to change those relationships as well. And I also wanted to touch a little bit on the idea of relationships, because I think there's the relationships and those components that need to be part of a good relationship. But I think also someone mentioned a little bit in the chat earlier too, knowing the whole person. And sometimes, you think about sort of these system level things, but even the one-on-one relationships that we have with our patients, if we come to learn people for who they are, what's valuable to them, but also show ourselves as humans, because I think in medicine, we sometimes have this little barrier and we don't want to kind of know our patients and show who we are. But those are really powerful moments to be able to have. And I think, for me, one of the things that I found most powerful when I was going up to some of the smaller communities in Nunavut, for probably at least 6 months, I used to bring my infant son with me up for community visits. And that was such a way to really build a relationship with other staff, with other patients. My son too, had his ayahs, his aunties in the health center who would take care of him, still ask about him when I'm in touch with him. And, that ability to connect is really, I think, one of the key starting points for where we can move forward with a lot of this work and show that we really want to be true allies. I think there's also this sense of listening deeply. And I think, so beyond just learning, really reflecting on what we're hearing, what we're learning. And there's probably some messages within that that we can take when we move our path forward. And from that, the other piece too with that is that every community is different. So there's not one answer. I know there's been some even comments before we started this session about what's the sort of, solution for this? Well, the solution is going to depend on the situation. And everyone is unique. Certainly having worked in rural communities, there's a phrase that we use there. If you've seen one rural community, you've seen one rural community. And I think this is the same reality. So it's all about developing those relationships. It's all about asking and then taking action once you've sort of learned and understood what the situation is.
then moving forward with action. I also wanted to touch a little bit on what Dr. Lem mentioned, because I think sometimes some of this work, and especially if you're working in really northern remote regions, and unfortunately some of the work I had in Nunavut, we're still faced with very deeply rooted colonial structures that affect providers as well as patients. And, I think sometimes we need to recognize this isn't always a comfortable road to travel, but it doesn't make the journey not worthwhile. And sometimes you may be faced with accusations that you may feel you can't, speak to fully. But I think sometimes we pass judgment without quite understanding what may be in the background and going on within someone's life. So when you're trying to be an ally, being sort of humble and also looking with kindness at those around you who may also be trying to do some of this work, because we will make mistakes, or there will be things that we're limited in, and there may be opportunities later to address a situation in a different way. Some of those structures are just so deeply ingrained in that white supremacy, essentially, that controls a lot of how our health system works, is very difficult to shift, and we need to take small steps where we can. And I think the other thing I've seen as I've moved into leadership roles is that there's even more of a responsibility there. And I think if you're on a board or, sitting on a committee or, in the leadership position within a health organization of some sort, to look for those opportunities to really influence some potential changes and be that voice if you do have that stronger voice to take action.
I really love how both you and Dr. Horn brought in the concept of relationships and how allyship is based on relationships. And, it's not just about, what we say or what we do, but it's about taking those steps alongside each other. So I found that really a helpful example that you were giving of what Dr. Horn was talking about earlier. But you also talked about mistakes. And I know this is something we heard from participants beforehand, before this, and something I've heard commonly from settlers who are really worried about working with Indigenous peoples and Indigenous communities. They're worried, like, well, what happens if I make a mistake? I don't want to say something offensive. I don't want to do the wrong thing. There are many barriers that come up when we're talking about this work, whether it's the mistakes or some of the systemic issues that you already brought up. And there's also people who don't work in Indigenous communities, and so wonder how to support this work if they're not working in Indigenous community. Wondering if you can tell us a bit about your experience, share some of your expertise on these barriers, the fear of mistakes, and also what people can do even if they're not working in an Indigenous specific community.
Yeah, so I think just attending this session is part of moving along that path. So learning and taking opportunities to read about reconciliation, some of the sort of historical treaties and elements in our system that have existed, the role of white supremacy within our healthcare organizations, and seeking out those opportunities where they exist. So even if you don't have a majority Indigenous population that you're working with, this is all work that we need to embark on, and learning, I think, is one of the first steps to it. I think mistakes are something that will happen, and I've heard people say, if you're not making mistakes, you're not doing this work. And so it may not be comfortable all the time, but I think this comes to the humility that's also been mentioned, right? And if you come from an honest place and your intentions are good and you're trying to do better, and you take ownership of the work that you're doing, then I think that's the best that we can hope for. And I think that my experience certainly has been, there's an incredible generosity there in doing this, because we're actually taking the effort to kind of move along this path. And I think there's sort of an interesting parallel with rural medicine when I think about this. And medicine in general, we kind of have this imposter syndrome, right, that we often experience. And in rural medicine, you get really good at dealing with the imposter syndrome. And, you're not going to know there's a case that's going to come in and you don't really know how to deal with it. You're going to look up, maybe some information on YouTube or a video to try to do this procedure you haven't done before. But our communities expect us to provide care and do our best. And I think this is sort of the same thing. Our communities and Indigenous patients expect this of us. And so we really need to be kind of doing our best to do this work, and learning and understanding and coming to it with good intentions. And then I think the other piece too, once you've sort of learned more, is starting to notice where things are happening, right? And being more observant of what's going on around us in those day-to-day patient interactions, in maybe teaching roles that we have, in curriculum that's developed in different leadership spheres, in terms of how our clinics are structured. There's a lot of little ways that we can kind of notice where all these little or bigger areas are. And the more we notice and then speak to those things, I think that's another way that we can start doing a lot of this work.
Maybe I'll ask Dr. Horn, same questions to you. Do you have anything else to add on the fear of mistakes, the barriers, or even for those who don't work in Indigenous communities, what they could do?
So, like it was said before, if you're not making mistakes, then you're not trying. And unfortunately, there is a culture in medicine that you can't make mistakes. So it makes you very afraid to try. But when there's something that's never been done before, then you can only try and do your best and reflect, particularly on the good stuff, but as well as the bad stuff. And as a physician working in a community and inviting medical students and residents to Akwesasne for their 1 month rotation, we've had about, in rural medicine, we've had about 200 students and residents from McGill, Ottawa U, and Queen's medical schools, and have learned quite a lot about how to do a respectful rotation. And so that includes, having a really good orientation package, making sure that there is a point person for the trainee to be able to contact that's not necessarily a doctor who's in the system, having dedicated time every week to learn from community members about the culture and the language and get toured around the community, not by a doctor. Also to interact with the other people in the community who are also providing healthcare, who are for the most part Indigenous, like our home care nurses and our, people who work in the pharmacy and of course, working on the ambulance services, like basically having them permeate throughout the entire community to be able to learn what's there. So then you have a better expectation and you know the limits of your allyship. You can't be a great ally if you don't have any idea of what the situation is. And the best way to do that is to become immersed in it. And the best way to do that is for schools to make these rotations safe and to and make sure that there are certain things in place to make sure that those students are having a good experience. We all have edge of the woods ceremonies, which is when you first enter a community, and we don't even teach those at all, and we really need to do that. So people remain scared because they have no idea what, there's no orientation, and we have to change that, but you have to pay for it, and that's the big problem. There's no funding model in there to be able to provide these orientations to our students, so they leave actually with the same with the knowledge and the ideas and the ways of thinking of the people they meet, which are the doctors. And so it's very limited. So we may, have people go up into these communities, which is a good thing, but it can be a lot more. And unfortunately, if you don't do it well, then you're just you run the risk of just exacerbating the prejudices that the person went up there to begin with.
Okay, I want to make sure that we have time for questions. So while everyone's thinking about what questions you want to ask, I'm going to go to each of the panelists to just give me like 20 seconds there are some medical learners on the call today. So while everyone's preparing their questions, is there one quick thing that you'd each like to say to medical learners who want to see a change, who are just starting out in their career? And we're going to go Melissa, then Sarah, then Augusto, and then Shika's going to jump in to help us moderate the questions. So I'll step out and just do a really brief there and then move to Shika.
Okay, I guess I'll go. Try to keep this to 20 seconds. I want to underline what Dr. Horn said, which is that relationships take time and presence. And I think the fact that I started my clinical education in Sioux Lookout really kind of set the stage for a career that made me very interested in Indigenous health and wanting to support and work in those communities as a full-fledged doctor. So I think I feel so. You know how we have kind of mandatory rural rotations? I feel like there should be kind of mandatory time spent in and around Indigenous medicine. So whether that's on, in actual communities or in cities, where it might be harder to access that kind of experience in friendship centers or clinics where, where majority Indigenous people go to. So I think just taking the time to be in those places is really important.
Dr. Lesperance?
So my initial one was going to be slow down, take the time to really learn, listen, and experience. But I think, maybe following on Melissa's, I would say getting outside too of the clinic and into communities and really learning more about culture and who people are as people.
And Dr. Horn?
Yeah, so I I would say that we've worked really, really hard as Indigenous physicians to be part of this movement to get us here where we are. And we've had a lot of learning opportunities, with Brian Sinclair and Joyce Echaquan and the people that I met during my training, who really have created a consciousness. And so we have that in our memories, in our experience, and we're on your boards and we are in your committees and we're on your working groups. So listen to the Indigenous people in those places, because they come from a history and an experience that might be very different than yours. And I would suggest that now you don't just have one person on those groups, you have at least 2 Indigenous people, even 3, because we're so varied, we're so different. There's nothing similar, just like one rural community is different than the other one. It's the same thing with us, with our people. And I think recognizing that and support us to be in those spaces so that we can safely speak and talk, so that we can create these relationships, so that we can get the best truths and we can make the best decisions.
Shika, over to you for questions.
All right, sounds good. Thanks, everyone. All right, folks, just because we have a large number of people on this call, which is, by the way, absolutely fantastic. We're so thrilled for it. If you could add your questions to the panelists in the chat, that would be great. And if you have a question to specific panelists, if you can let us know as well, and we can redirect your question. So wait to see some come in. While that's happening, I actually have a question of my own, if that's okay. And I thought maybe I'll direct this one to Dr. Lem for now. Just in thinking of where to start. So I think when the poll question came up, a few people were well on their way, and a few people hadn't started this work at all. If you had, advice to give for someone on where to start when it comes to allyship and reconciliation, what would you suggest?
Shika, it is a huge area to start to explore in. And I think maybe I'll take some parallels from my work with planetary health. And you kind of want to tackle the whole issue at once. You want to become the best ally at once, but it's hard. You can't. It takes time and it takes work. So I would suggest kind of like what I did in my work on planetary health is think about something that you're really interested in and really passionate about. And then look at kind of gaps that may exist in your own practice or your own circles. And then also think about what your special skills are and what your networks are. And then at the intersection of those three, may just be where you want your entry point to be into this area, where you might want to start reading, where you might want to seek out knowledge keepers who have information and knowledge about these areas. So instead of trying to like tackle the whole thing at once, think about one area that really resonates with you and enter from that point. And I've seen this happen with my work in planetary health. Once you enter at one point, it's just more and more and more layers of the onion. After that, you learn more, you want to learn more about other areas, and you just build on the knowledge. And good work that you can continue to do.
That's great advice. Start from where you're interested, right? Like go with what you're interested in and build from there. Thank you. That's fantastic. I saw a question just came in from someone who said, for doctors joining the Canadian medical system from overseas, so an IMG, what is our entry point to learn about Indigenous people? Dr. Horn, maybe direct that one to you.
Yeah, I think this is actually really, really important. In medical school, I was directed in my training during an internal medicine rotation to see certain numbers of patients in a certain order, and the last person was an Indigenous woman who was frankly completely uncared for, and it was actually, it was so awful to see that, she ended up dying, and I was so upset because I didn't see her early enough to be able to advocate for her. Like there was nobody in that whole emergency room advocating for this poor woman, who had literally been dumped on the sidewalk by a cab. And I thought, well, what does this person who's from another country, who's here doing his residency in internal medicine, what does he even know about our Indigenous women? Indigenous women are the most vulnerable people of everybody in Canada, and that's why we had to have this big inquiry about murdered and missing Indigenous women and girls. And so I really think that it's not just learning about Canada and the flag and the songs and all the history that they learn. You must have something there to talk about, about Indigenous people, not the same old that we all went through in high school, but something really that is substantive and helps them understand, our situation, and recognize that a lot of the things that they're seeing and from other people may be actually wrong and very, very harmful. I have thought about this woman a lot over the years, and what would I have done differently? It was a different time back then. That was 25 years ago. Anyway, and it's just and I'm hoping that it's better. But yes, I don't know the answer, except we must dedicate some of the curriculum resources to our new visitors to this country, not visitors, but new people coming to this country to live, about us, and not the same old, because that obviously hasn't worked.
Thanks for sharing that story. I mean, this reminds us that this learning is so important for every one of us. And someone put in the chat there that, whether you're new to Canada or someone who's been here for a long time, a lot of people living in Canada don't know any of this. It's the same work. And I think and unfortunately, sometimes the same outcomes, irrespective of and poor outcomes, irrespective of where that person came from. But I think what you're saying is we need to start somewhere. You need to get out there, and you need to learn wherever you're from, because the reality is that Indigenous people have very tough. Sorry, go ahead, Dr. Horn.
I didn't mean to interrupt you.
Oh no, that's okay.
I'm sorry. I wanted to say that one of the biggest problems is we have this assumption that you learn only from your people who are ahead of you. Like there's this big hierarchy that exists, and the people who are in that hierarchy have very entrenched ways of thinking that reflect their entire history, and that's where that that racism comes from. So we actually have to listen to our young people because they're the ones who have come through in a different way with a different acknowledgement and maybe different experiences in a more healthier way. So in many Indigenous communities, we have children that children select us as their parents. They come with a special gift, and our job is to create the spaces for them to have experiences and find those gifts, and then we learn from them. And so it's generational, but it also is from the ground up. It's from our children, and so we can't just have the same people teaching the same thing. We really have to expand and really include the younger people to help us learn how to do this in a better way.
Thanks, Dr. Horn. Break out of the paradigm, right? The paradigm
Yeah.
that we have is not working right now.
No.
Absolutely. Thank you for that. Dr. Lisprance, you had something to add?
Yeah, just really, I guess, in terms of some specific things that I found helpful if you're kind of earlier in that journey of learning. So I did find that the Canadian Medical Association's Unforgotten Film series is kind of a helpful place that guides you through a few elements related to different themes around Indigenous health and some of the history. And some of the reports, like the final report of the Truth and Reconciliation Commission and report on missing and murdered Indigenous women and girls, as well as a couple of books, like one that's called the 21 Things You May Not Know About the Indian Act, and Jody Wilson-Raybould, who's a former senator, who also wrote Truth and Reconciliation, I think was the name of her book. There's a ton more. And I think certainly we have some resources as well on the CMA website, but those are a few that I've found really kind of good places to start in terms of some learning.
Thank you for that. And I put the link in the chat as well. A very poignant film and very hard to watch at the same time, but a really important thing to watch. So thank you for raising that. Okay, just a couple more questions in the chat here. Want to make sure I can get to all of that. So we have one question around what do you do when there's so many things? So the question's really around there's just an overwhelming number of things that happen for a physician today. They're overworked, burnt out, and this feels like another thing. How do we add that to what seems like an overwhelming schedule already? Maybe Dr. Horn, do you want to try that one first?
So you probably, okay. Yes, there is a lot. And part of it is because we're doing it from a cognitive point of view. Like we need to know all these details because that's what medicine is, right? Like all this stuff that we have to pack into our head so we can easily retrieve it, but we don't actually figure out how to use our like heart. And if we all did, put a lot more energy into creating healthy outdoor spaces for us to be part of, to be able to go outside, go into nature, go into a national park, go onto the water, and then you start to have commonalities because that's what we're talking about when we're talking about connection to the land and relationship to the land. That's what we're talking about. And if you can understand that language, then you have a better focus for your allyship. A lot of allyship happens when you have a common goal. We all are humans. We all are on this one earth. We do have commonalities more than we have differences. And we just have to find those. In medical school, we just have to take care of ourselves. And maybe that means that we got to get outside and start feeling with all of our senses, not just our eyes and ears and brains. Yeah.
Thank you. And you're right. This is part of the work that you're already doing. It's part of that. And it continues to be about acting in a good way and listening before speaking, which is the one thing I heard once, right? I think the teaching I heard was you have 2 ears and 1 mouth for a reason, so that you listen more and speak less. I always kind of remind them and tell my children that all the time as well. So I find that a really effective teaching. All right, I know we have a few more questions in the chat. I will have to keep us moving. I promise to do that just because we have to get to our breakouts. Thank you thank you to all of our panelists. Thank you to Dr. Reimer for moderating as well. Really appreciate the conversation. Thank you for being vulnerable and sharing your examples as well, and for sharing the teachings. Really, really appreciate it. We are going to move up to our breakout. Okay, and you'll see it come up on your screen with a question that we have for you. Folks, when you register for the session, many of you told us, as I said before, that you really want to talk about allyship, right? And a lot of the questions in the chat were that as well. And so a key role of allyship, as we discussed today, is to actively engage in anti-oppressive work, right? And demonstrate it through the relationships that you can build and cultivate. But it's also about learning from each other. And a lot of you, when we did the poll, told us that you're well on your way. So what we want to do is break out into small groups and talk about your experiences as well. And so the question that we have for you is, considering your experiences in medical education, in training and in practice, what barriers have you seen that hinder Indigenous self-determination healthcare? And I would say take it a little further, that even hinder allyship. At the same time, also want you to think about, where are those moments? Where are those bright spots that work really, really well? So we're going to spend about 30 minutes in our breakouts talking through this, sharing our experiences, sharing our questions. So even if you don't know, ask. Let's see what others have to say. We might learn something from one another again. So we're going to put you in breakout groups in a moment. You will all have a facilitator who will help guide you through that. We also have a note taker who's going to take notes so that we don't miss any of your fantastic thoughts. And we will produce a summary report at the end of this as well, so that you have something to take to remind you of the great conversations. We'll also make sure that each of our panelists will be in one of the rooms as well, listening in and contributing their ideas as well. So once again, thanks to our panelists, and I'll look to my colleague Daria to get us to our breakouts. Welcome back, everyone. I think we're all back. I'm going to give another 10 seconds or so while everyone filters back from their breakouts. All right, hopefully you all had a moment some time to discuss, ask your questions. I know we had a great discussion in our group as well. What I thought we could do as part of the wrap up is just invite our panelists and Dr. Reimer to share a couple of points from whichever breakout group you were in, that a couple of things that resonated for you as a way of just hearing from each of the breakouts. So Dr. Reimer, maybe start with you.
Sure. I mean, there were so many good things. I really liked that one of the first things I heard was a conversation about relationships and how allyship can involve a lot of one-on-one work, where you really need to be talking to the people in your life who are experiencing these barriers and these harms, and learning from them about what's going on, to be able to inform yourself about what that community needs and what you should be advocating for and where you can make that difference. Another conversation that I really liked hearing was that a lot of our focus tends to be on the interpersonal aspects of racism, of harm, when in fact the system itself is often where the harm is happening, and that systemic racism is something that's really sometimes hard for us to recognize, because we see the way the system is as a norm, instead of as a colonial structure that is causing harm to people. And so that conversation was really great to listen to and hear about how, this is a frame I've seen elsewhere that wasn't discussed there, but where when you're thinking about, equity and inclusion, you're thinking about who's at the table, are they being listened to? But the question should sometimes be, why is the table the table? Who made this table? And is this how we should be making decisions? Is this the right table? And so really taking that step back to question our systems and say, does the system make sense? And looking at it more holistically than just, does it make sense to the physical health and well-being of people, but instead including the Indigenous perspectives of spiritual, emotional well-being, mental well-being, and all of that into how the system is built. So those were just a couple of the things that stood out to me as I was jumping from one room to the next, but really great discussions, and I'm looking forward to hearing what the other panelists heard.
Thanks for sharing, Dr. Reimer. I once had someone say, when you're feeling uncomfortable, you should ask yourself why. And maybe it's because something's different from the colonial structure you're used to, and it's disrupting it. And maybe that's it, and not that there's anything happening that's wrong, but maybe it's because you're just so used to one way. So thank you for bringing that into the room. All right, I was going to turn to Dr. L'Esperance and then Dr. Horn and Len. So Dr. L'Esperance, you're next. Let us know one or two things that you heard.
All right, thanks so much. So we had some great discussions. I think it sort of started on the topic of some of the overt racism that still exists within the healthcare system. And, sometimes we start talking about the microaggressions, but there's still some really kind of outright um, examples there that, just kind of hit you in the face. And how to kind of deal with that when you're either coming before or after as an individual. But then that sort of shifted into, yes, we need accountability within our systems and our structures to deal with those things. But then we also need to think about our unconscious biases ourselves and what are we maybe sort of doing that we're not aware of, and sort of making sure that we're starting to reflect on some of that. And then the second piece that our group talked about was also the system, and what within the policies and sort of challenging policies that exist in the colonial structures, how we can advocate for changes together. And the example that our group was talking about was medical travel, particularly for pregnant women in the north who have to leave their communities, either come down to somewhere like Iqaluit or even to a city like Winnipeg to have a baby, and how disruptive that is, and how many of us feel frustrated with that, see the colonial structures there, and so how we can kind of work together to shift that and make those changes.
Sounds like a fantastic discussion. Thanks so much for sharing. All right, over to you, Dr. Horn. Any reflections from your session?
So, yeah, we had a really quiet group. And we had some discussion. I will say though that I think this is a reflection of the society in which people are very afraid to actually speak up. They don't want to be wrong, and they don't want to show anybody to see their face, so they keep their camera off, and that makes me kind of sad because this is a safe place to have these discussions. So I think we didn't have as robust a discussion as I would have envisioned. But there was some discussion about how the medical field does not acknowledge, doesn't respect, and even the fields such as midwifery, our doulas, our traditional medicine people, and they may do it in like they think that they're being an ally, but they actually haven't reflected enough to realize that they're actually not, and that they do have implicit bias that they have not been able to reflect. So then the question is, well, how do you get somebody to be able to reflect? And actually, that's really, really hard to do, because somebody has to, it's like when you have a personality disorder, and you can't change that person's behavior unless they know that they have this, and they know that it's causing them to not function properly, and that it bothers them. And then you can start to participate. They can participate in trying to change their behavior, their perspectives, etc. So when you have somebody who has no knowledge and is not aware, then it's very hard to have them not be defensive, and it's hard to have them have insight or humility. So this happens throughout medicine because it's so hierarchical, because many people do not feel safe to be able to to challenge that hierarchy, and that's it's a bit sad. So this is okay, I'll just stop there. Thanks.
Thanks, Dr. Horn. Hearing you say we need to push against some of the medical culture paradigms that we have, to allow space for people to feel safe to speak up, to challenge, do things differently. And I also hear what you're saying around awareness, right? We need to be careful to check our own awareness and be open. So thank you for sharing that. All right, Dr. Lem, you were in the breakout that I was in. You want to share a couple of thoughts from our group?
Sure. We had a great group with a lot of discussion, actually. So I feel very fortunate to have been in that room with a lot of powerhouses, and we had a very kind of solutions focused discussion, which is interesting, which is a way to break down those barriers and to kind of kind of change minds and educational structures from the outset. So Annette Cormier, she's in New Brunswick. She left. She wrote a message in the chat. She was talking about some of the learnings that they had from establishing basically an educational program that stemmed out of another program that started with one around fetal alcohol spectrum disorder. But anyway, some of their learnings were that co-creating and walking alongside each other on the journey is essential. And it takes time to do it right. Something that is kind of impressed upon us in medicine is getting it all done really quickly. But you can't do that when you're building relationships. You want to take the time to do it right, learn the context, bring in all the right partners, and something that starts really small can expand to so much more. And it's a really kind of great program. They've broken down barriers by involving elders and immersing students in community experiences with Indigenous peoples. And a lot of the students have said that this is an experience that they'll never forget, and it'll forever be a part of their approach to patient care. So I think this speaks to how important it is to educate and involve medical students from the beginning, so that they see patient care from a different context that's inclusive of their whole patient. And then we had a vice dean of education also in the room who spoke to the pressures around again having learners trying to feel like they have to get it all down. They have to get the whole history, understand the whole patient in one encounter in like 10 to 15 minutes. And so kind of taking histories and trying to provide holistic care can be more performative than actually, based out of a true intention to care for the whole person. And so, what she said was that, again, sharing entire stories, learning your whole patient can take time, and relationships and continuity are important, and that trust is earned by this time and continuity, and just to try to be more curious more often and kind of push our own comfort zones and ask questions about things we might not understand, and be comfortable with that discomfort. And being curious and learning more about your patient over time can really result in better overall outcomes for not only your patient, but kind of the overall system that you work in. Thanks.
Great summary, Dr. Lim. Thank you. All right, we're almost done, folks. I'd like to now pass it back to Dr. Reimer, who's going to share some closing remarks. Over to you, Dr. Reimer.
Thank you so much. Thank you to everyone who joined, to the panelists. It was a really great opportunity to learn. As you all leave here today, I invite you to continue your personal journey of reconciliation and reflect on how to be a better ally, and question how collectively we can do better in providing culturally safe care. We heard several examples today. We heard about some of the really tragic examples where Indigenous people didn't receive the care they needed, and the outcomes were devastating. But we also heard examples of where things have worked well and where community has benefited from these positive steps. And so I hope you walk away feeling inspired to continue down this path, to learn, but with the humility to be corrected when you're making a mistake, because that will happen. And so while we're certainly fearful of making mistakes, knowing that that's going to happen, but knowing that when you have the humility to accept that correction, that can help build the relationship, is also something that I hope people take away to feel more encouraged as we go into these relationships. So whether you are a medical learner, whether you're a practicing physician, we all have a responsibility to help build a better future for patients and for our colleagues. And so I do also, you'll see there's on the slide there, I want to share some resources from the CMA that will come up that are there on the screen that hopefully will assist you in your journeys moving forward. We will also circulate them via email afterwards as well. But I know there were lots of questions about where people can start. So hopefully this is a nice place for people to start, as well as there were so many resources that you all shared in the chat that I know we're going to try to collect all of that for our follow-up, our summary document as well. So thank you to the team who put this all together, the interpreters, everybody working in the background, as well as the panelists and all the participants today. We had a great discussion, and I'm just thankful to all of you. So I will pass it back to Shika to wrap things up.
Thanks, Dr. Reimer. Folks, you're almost done. We have one more ask of you, if you don't mind. We try to do these webinars and try to make each and every one better and better as we go. So a poll will come up. It's an evaluation poll. We'll have a fulsome one that we'll send via email after this call. But if you could just answer those 2 questions for us, it really makes all the difference for us, because we can make sure we can hit the mark each and every time. And we hope to continue these webinars into 2025 as well. So if you like what you heard, or even if you didn't, please let us know so that we can do better. As well, while you're doing that, on your screen, you will see what we call a preference center. If you want to hear more about these webinars, if you're always, I didn't know this occurred, and that my friend told me, if you want to get on our list, please log into your CMA account. Please go to your preferences and tell us, what do you want to hear about? If it's Indigenous health, add that. If it's EDI, if it's physician health and well-being, whatever it is, we only send you information that you want to hear about. So please go ahead and fill that out so that we can send you what you want to hear about. Other than that, I'm seeing everyone slowly answering those questions. If you could please, there's 2 questions. You might have to expand the screen to see both polls. If you could do that for me, great. As they're coming through, I just want to again echo what Dr. Reimer said. Thank you very much for your participation today, for being vulnerable, for asking questions, and for continuing to want to see change. On the behalf of the CMA staff here, thank you very much for your participation, and enjoy the rest of your day. Have a good one.